HHS and CMS set the federal rules for behavioral health, and Medicaid is the single largest payer for addiction and mental health treatment. Medicaid is the largest payer for addiction and mental health care, so federal policy directly shapes what you can bill and collect. A plain English guide to the federal agencies every behavioral health operator should know. We cover each agency, the Medicaid waivers that expanded treatment, the grants that fund it, and the Support Act. 3 names matter most. HHS is the umbrella department. CMS runs Medicare and Medicaid. SAMHSA is the agency at the helm of federal behavioral health. CMS sets Medicaid and Medicare rules and approves the state waivers that decide which services you can be paid for. SAMHSA administer the grant programs that fund prevention, treatment, and recovery supports nationwide. When CMS opened Medicaid to inpatient SUD treatment, at least 17 states had waivers approved by late 2018, and programs there could finally bill Medicaid for residential care. Historically, Medicaid could not pay for adults aged 21 to 64 in facilities with more than 16 beds, limiting residential options. The flip side, when Arkansas added work requirements, over 18,000 people lost Medicaid in 2018, a swing in your payer mix. The Post's takeaway for providers. Operational resilience starts with a behavioral health EHR designed for compliance documentation. A behavioral health EHR designed for compliance documentation is designed to help programs adapt to regulatory changes. Paired with a CRM that tracks referrals and admissions, it is designed to keep programs operating as rules change. CMS controls 4 levers that decide what your program can be paid for. Here is what each one does. From residential beds to work rules to health homes, these are the CMS decisions that move money to or from your program. Lever 1. Section 115 Demonstration Waivers for Inpatient SUD Treatment. In 2017 and 2018, CMS invited states to apply for Section 1115 waivers to cover inpatient SUD services in institutions for mental diseases. By late 2018, 17 state waivers had been approved to pay for residential opioid use disorder treatment in IMDs. Lever 2. The partial repeal of the Medicaid IMD exclusion. The Support Act partially repealed the IMD exclusion, letting states use federal Medicaid funds for inpatient SUD treatment up to 30 days per patient per year. In November 2018, CMS said it would also consider IMD waivers for serious mental illness and emotional disturbance in youth. Lever 3. Medicaid health homes and wraparound services. Under Support Act authority, an enhanced federal matching rate lets states develop SUD health homes coordinating medical and social services. CMS guidance made it easier for states to pay for transportation, housing support, and peer recovery coaching through Medicaid managed care. Lever 4. Eligibility rules that decide who stays covered. CMS approved work requirement waivers for states including Arkansas and Kentucky in 2018, tying coverage to work or volunteering. Courts halted and reversed the policy. As of 2025, work requirements are not in effect. But the source notes such reforms remain on the table. The Support for Patients and Communities Act of 2018 ties most of this together. Here are the provisions operators feel directly. It codified that qualified physicians can treat up to 275 patients with buprenorphine, up from the previous 100-patient limit. It made permanent the ability of nurse practitioners and physician assistants to prescribe buprenorphine for opioid use disorder. Starting in 2020, Medicare covered opioid use disorder treatment by opioid treatment programs for the first time. Beyond Medicaid, SAMHSA grants fund a large share of treatment. 2 streams matter most for operators. By 2020, state opioid response grantees had distributed over 645,000 naloxone kits and documented 32,300 overdose reversals. SAMHSA's substance abuse treatment budget climbed from about $2.1 billion in fiscal 2016 to $3.7 billion in fiscal 2018. HHS is the umbrella department that houses CMS and SAMHSA, and HHS leadership sets the tone that filters down to your funding. The HHS secretary at the time, Alex Azar, emphasized the need for more inpatient and residential options for mental health. The federal drug control budget, which includes HHS treatment funding, reached over $40 billion by the mid-2020s. The proposed fiscal 2025 budget request for SAMHSA was around $8.1 billion. When CMS waivers, grant rules, or coverage shift, your documentation and intake have to keep up. Behave Health is built so they can. The EHR is designed for compliance documentation, helping programs keep records aligned as rules change. A connected CRM that tracks referrals and admissions is designed to help organizations adapt without disrupting care. Stop letting CMS and SAMHSA rule changes catch your program flat-footed. Book a 20-minute demo at behavehealth.com. See the compliance-focused EHR and the referral and admissions CRM built for behavioral health at behavehealth.com.